Thank you very much, Richard. Once again, thank you to Klaus for the invitation to this wonderful meeting, and thank you, Richard, for teaching me everything I need to know for the rest of my career. I loved your talk. Thank you. So Klaus asked me to speak a little bit about complications of hip arthroscopy. I come from Warwick, which is right in the center of England. My office is in the left-hand tower just there. No, really it's not, but you must come and visit me sometime. So it would be reasonable to think that hip arthroscopy could not possibly be safe. And I remember when I began to do it in the 1990s, this was the view. That will be very, very dangerous. So I had a little look at the first publications about complications. And in fact, the first publication which is specifically about complications of hip arthroscopy comes from the Schultes Clinic here in Switzerland. They reported 19 cases and 3 complications. That was in 1996. And they were describing a lateral approach, which you will see is not so far different to what I do now. I worked with Richard Villa in the UK. He introduced me to the idea, and we published a series of his patients in '99, 640 patients with a low complication rate and no serious complications. So that gave us encouragement that this was okay to do. Since then, there have been many, many publications. I picked these 2 out. So the one on the left is a systematic review, and the important thing about it is the very large number of cases, so 36,000 operations. The one on the right is much more recent. It was led by Chris Larson, but also Paul Bollet, who's here today, was part, and John Cloese, and Brian Kelly. These are very highly experienced hip arthroscopists, and they prospectively recorded all their complications. So on the left there, I think you have what is probably the lowest value for complications from very large numbers of retrospective studies. And the right, you have what is probably a high ascertainment of complications, but from experts. And bear that in mind. And when I give you figures during this presentation, I'll give you 2 figures, one on the left, which is from that big systematic review, and one on the right, which is from those experts, but with high ascertainment. You might reasonably expect that the high ascertainment will give you a higher complication figure. And I'm going to divide these complications up into 3 groups, those related to traction, those related to the procedure, and those related to the surgeon, and that will make more sense as we go. So most people have used traction for at least part of the operation that they do. Actually, not everybody. There was quite a strong tradition in France to not use traction for hip arthroscopy, but they didn't work in the central compartment. Some people like me have used a lateral position. I would think in the world now, more people use a supine position. You see that in both of these cases, there is a post in the groin pressing on the perineum, and that will become important. Now you have to hold on to the foot so you can pull on the leg, and most people use some sort of boot. It's a bit like a ski boot, but instead of having one that fits you, and I bet every one of you's got a ski boot that's specially made for you, in fact, you have one that's the same for every patient, and you just make it very tight, which means that lots of patients end up with dysesthesia in their foot because of that compression. You can see that the prospective study that was done by our American friends comes up with a nearly 1% rate of people saying that their foot's pretty sore after the operation. Virtually none of them have had long-term consequences, so it's temporary. I actually use a tape system, so I'm sort of making a personalized boot for each patient. My experience has been that has a much lower rate of foot pain after surgery. While we're talking about nerve injuries, I'll mention the lateral femorocutaneous nerve. It's right in the way of the most anterior portals. And so if you use a supine approach with more anterior portals, you have quite a high rate of injury to it, which sometimes doesn't recover. If you use a lateral position with more posterior portals, then most of the literature suggests that the rate of nerve injury is virtually 0. So that may be something to take into account when you're planning what approach to use. Just the straightforward traction could cause an injury to the femoral or the sciatic nerve. There's been virtually no reports of femoral nerve injuries, but very low rates of sciatic nerve injuries. I've had 2, both of them were temporary, but both of them were very worrying because the patients had a very profound sciatic palsy when they woke up from the operation. One of them took 3 weeks to recover completely. I don't believe it was anything to do with portals. I hadn't put portals near the sciatic nerve, so it's just longitudinal stretching. But actually, by far the biggest problem with traction is pudendal nerve problems or pressure effects on the skin of the perineum. So the pudendal nerve is not something we ask patients about very much. Have you got any loss of sensation in your vagina or your clitoris or in your penis? Or how are you having any problems with your erection? These are not questions that most of us will ask our patients in the clinic. But if you do, then you will discover that 1 or 2% of people will say, yes, I have had a problem with that. Most of them get better over a few weeks, but it's frequent enough that I now warn all of my patients that this is likely to happen, and if it does, give me a call, and I'll just reassure you and talk you through it, and we'll watch it get better. Skin injury is awful, and I've had 2 bad ones. One man with a scrotal injury where his scrotum was caught between the perineum and the post and compressed, and so he had an ischemic injury to the skin there and lost a patch of skin of his scrotum. And one woman who had a lot of swelling of her vulva and was very, very upset about it. So these are not trivial complications. People have tried to avoid it, particularly in the supine position, by using a very large cushioned post, and that does seem to help, but it doesn't abolish the problem. And more recently, I should say also that we have found that the problem is more likely if you have a longer period of traction, and it seems to be the length or duration of traction more than the intensity of the traction that matters. More recently, people have thought, well, maybe we could do without the post. And I think you will have all heard something about this. There'll be someone around you who's making a big deal of post-less traction. Actually, I think it's pretty straightforward. You just put the patient on the table, head down enough that the counter-traction of their body makes it possible to avoid a post. And I suspect we will gradually move towards doing it this way to avoid these perineal pressure effects. There have been a few studies of this. Not surprisingly, they demonstrate that patients who have no post-related complications. Now, that's sort of obvious, isn't it? What's perhaps a bit more interesting is that, just as I was saying a minute ago, if you prospectively ask people about these symptoms, much more often do they tell you about them than if you try and find out about it in a retrospective study. So I think it's something we've not been aware of as much as we should be. My second category is procedure-related complications. Now, infections, well, of course, we're worried about that. We're surgeons. We always think about that. Fortunately, the rate of infection is very low, and even deep infections that we'd be worried about particularly is a very low rate. And I think that's probably something to do with the fact that we're washing huge volumes of water through the joint throughout the operation. So I'm now really pleased that 50 litres has gone through this patient during the operation because I know the risk of infection will be very low. DVT is also very low. Also perhaps reflects the fact that we have pretty young patients and we get them going quite quickly. It's not quite 0, but it is low enough that in an international consensus that I and 2 of the other people here did a little while ago, we found that there was no justification for routinely using thromboprophylaxis, although you might add it if there was a particular risk factor. What you should do is get the patients moving. Now, quite a lot of these patients are a little bit sort of sensitive. They think that they're going to have to really take it easy after this operation, and I don't like that. I want to get them going straight away. So in the hospital, I get them onto some form of early movement so that they know that they can do that. They don't need to be frightened of it. Intra-abdominal fluid extravasation causing a compartment syndrome has concerned some surgeons a lot. A few years ago, we in the Mahorn group did a survey. We found a lowish rate at 0.16%, but still much bigger than had been reported in the retrospective literature. The trick with that is to try to avoid high pump pressure avoid psoas releases, or at least not until the very end of the operation. And a few patients who'd had a piriformis release had a fairly profound compartment syndrome in their pelvis and in their buttock compartment. So just be cautious of those, and if you are worried about it, have a feel of the patient's abdomen and be prepared to stop the operation if you're concerned. Heterotopic bone formation, pretty unusual as a symptomatic problem, although I do think it's quite frequent as an asymptomatic appearance on imaging. So it's rare to have to think about doing anything further because of this complication. And instrument breakage, well, you're trying to get straight instruments to go around curves in the hip, so they do break occasionally. The commonest one I see broken is the guide wire. If you're putting a guide wire in, everything should be fingertip control. Don't ram things into the hip or they will break, and then you've got a problem of getting an instrument loose body out of the joint. But taken together, all these complication risks are quite low. And that brings me to the last category, surgeon-related complications. So AVN, and I'm going to call that surgeon-related, you'll see why. The risk of AVN is the one that terrified us when we started doing hip arthroscopy. Why? Well, because we knew that there was a risk if you dislocated your hip that you got AVN. We didn't understand the anatomy the way you've been taught it in the last few days. And so we thought maybe this will apply to hip arthroscopy too. Turns out it doesn't. There's only a handful of cases that have ever been reported. And I think that you should look at the vessels that are supplying the femoral head. You should make sure you can see them and that you protect them throughout the operation. And if you do that, I can't see any reason why a patient should develop AVN. Fracture, again, pretty frightening. If you have a young person, they get a femoral neck fracture, perhaps because you've over-resected bone. Fortunately, the risk seems to be very low. I've never had a case. Dislocation, this was a bit surprising when it first started to happen, and now there's a good number of dislocations that have been reported. And I think they're a consequence of bad surgery, usually because the stability of the joint has been compromised by bone removal or capsular loss. So those three, AVN, fracture, and dislocation, I think they can all be attributed to what the surgeon did rather than just being a random chance complication. But now we get to things where it's undoubtedly the surgeon's fault. So who in this room has ever seen this picture? Oh, come on, be honest. I've done this lots of times, and I reckon all of you have done it. I bet if you haven't done this, then you're not doing hip arthroscopy. So sticking things through the labrum, we really should not do that. It's not a good idea, and especially if you end up putting something as big as this switching stick through the labrum. Even worse would be to put a burr through it or something like that. So labral injury, I think these rates that are published are really pretty low. And this is where it's important now that that prospective study, the 0.9 figure, was just really expert surgeons. So that might be, let's say, 1%, the lowest reasonable risk that you could achieve. But for many people, especially beginning, that might be as high as 5–10%. Chondral injuries. Who's ever seen this in their operating room? Again, if you haven't seen it, then I don't think you're doing hip arthroscopy. That's a horrible thing. You're doing a joint-preserving surgery, and you've just put a sort of thing in and ground out a chunk of articular cartilage. We should feel very bad if we do that, and we should go away and reconsider the methods that we're using and the choices we're making. Now, this is, I think, our biggest problem. So here's a patient who had a cam, and they've still got a cam after the operation. They've just had a little bit of it chipped away. This is really bad. This is an operation that just didn't do the operation, or perhaps a surgeon who just didn't do the operation. Now here is a surgeon who did a bad operation, and I'm going to admit this is one of my early cases. So this is an operation where I've gone too medial on removing the cam, so I've created a sharp edge at the head-neck junction, and I haven't gone lateral enough in removing the cam, and I've created a horrible shape on the front of the head-neck junction. So who's ever seen a picture like this? Yeah, quite a few of you. And if I say, who's ever seen one come from someone else that looked like this? Everybody in the room is going to say yes. Here's another one of my cases, and I used to do a CT on every single case post-op, just to see what sort of a mess I'd made of it as I was trying to learn how to do reshaping properly. And this is one of the early cases when I used to do all of the cam shaping with peripheral compartment portals before I went into the central compartment. And I simply couldn't get to the superior and superior part of the cam using that approach. And that switched me to using a posterior portal and doing that superior and posterior part first. Now, in the fashion trial, a randomized trial that I ran a few years ago, both in the UK and in Australia, we found that at least 20% of the cam reshaping operations that were done in that randomized trial, where we did post-op MRs on all the patients, at least 20% were judged by an international panel to be unsatisfactory. So these were surgeons, all-comer surgeons really in the UK and Australia, but reasonably high-volume surgeons, and still 20% of them not good. On that shaping, I'll just make a point here. If you identify the point where asphericity begins, and often we do that with an alpha angle, and you start cutting there and you cut vertically down through the cartilage and into the subchondral bone, this is what you end up with. This is not a happy hip at all. This is a sharp edge that will catch on the labrum as it goes in and out. And it will be unstable because there's no labral seal in that concavity. This is what you want to achieve. And here we've got a smooth head-neck junction without a sharp edge. And we've got a concavity as it comes onto the femoral neck, and a convexity between the two of those. And it must be convex because it's a sphere. And that's quite difficult to do arthroscopically. It's much easier open, but it's difficult to do arthroscopically. But if we don't get it like that, then I'll put us in that 20% where it's unsatisfactory. And my final point is instability. So here's someone who's had a hip arthroscopy. It looks like half their acetabulum has been removed. I mean, this patient's got a center edge angle now of close to 0. Here's someone who's had a more subtle removal. So this was a patient who the surgeon thought they were just doing a little rim trim. But this patient's unstable because not only did they lose their labrum, because that became dysfunctional, but they haven't got that bit of the rim either. And the only way I can treat this patient is with a PAO. So here's someone who goes in for a day case arthroscopy and ends up getting a PAO, which probably won't be that great either. And here's someone who the shaping looks okay, but they've got no capsule, so their soft tissue stability constraint is lost. So instability and inaccurate reshaping, I think, are big problems now. Be careful with the capsule. I talked to you a little bit about this in the video yesterday. So cut it very gently, do it minimally, and hold it out of the way so you don't damage it during the operation. It was really hard to move around when we started hip arthroscopy, so we started making little capsulotomies. We extended them and then made them bigger. And then we thought, technically we could repair it. And then we thought perhaps we should. And I think we're now at the point where really most capsulotomies should be repaired. And this is my friend Chad Mather repairing a huge T-shaped capsulotomy just to demonstrate it can be done. So to conclude, hip arthroscopy patients do experience complications. This is not a completely benign operation. The traction-related complications, particularly perineal, can be pretty devastating, but the patients might not tell you about them unless you ask. I think we ought to change the way we do things to reduce the risk of those. But that risk at the moment is probably around 5%, mostly minor and transient. The procedure-related complications are quite unusual, and we don't need to worry too much about those, and I think we're pretty good at keeping those down. But the elephant in the room, the saying in England that talks about that thing we're not talking about, the elephant in the room is the surgeon-related complications, where I think we could reasonably expect that at least a fifth of the hip arthroscopies we do at the moment are not being done as well as they should be. And so patients will do much less well than we would wish them to. We have to address that, and that's mainly going to be about technology and training. Thank you very much.